disconnect audio in one.
Record.
Disconnect audio in one. So please, I'll let you know when to start.
Record.
Disconnect audio in one. So please, I'll let you know when to start.
Record.
So please, I'll let you know when to start.
Good morning.
Hi, Sandy. Welcome. So Schneider, on the hour, you can go live, and then Cassandra will tell everyone that that we'll start in a short while you play some music. Then when I turn on my camera, you can start.
Yes,
Hello,
we're starting in a
Schneider.
minute. We're starting in a minute.
Did you get what I was saying?
Good morning.
Yes, we're starting in a minute.
Yes, you're going live in a minute or right now, or once I finish. And then Cassandra will greet everyone and say that we will soon start. You can go live. I can hear sound there. Is it possible to take it off? So then you can play music for some time and allow time for others to join. I cannot see. I cannot see Dr. Mazin yet.
Good morning, everyone. My name is Cassandra Upchurch. I'm an RN in the United States, in Pennsylvania, in Collegeville. So I want to welcome everyone to our conference this morning, our webinar. So I want to welcome all to the third day of the Bloodless Medicine and Surgery Week 2025. So I just want to go over a few introductory items this morning. May is Bloodless Medicine and Surgery Awareness Month. Also, the Bloodless Medicine and Surgery Week, BMSW, and the month of May is meant to raise awareness about BMS. This is a superior form of healthcare and is organized by the Bloodless Medicine and Surgery Group in University of Calabar, Nigeria, in collaboration with the Bloodless Medicine and Surgery Society, BMSS, the Society for the Advancement of Patient Blood Management, SABM, and the Malaysian Society for Patient Blood Management. The theme of BMSW 2025 is Bloodless Medicine Care in Orthopedics and Trauma. I would also like to introduce my partner and co-moderator, Dr. Innocent Okawo, Medical Director of Safe Hands Hospital, Lagos, Nigeria. Innocent, are you on? Okay, so we just want to highlight that all questions that you may have, you can put in the Q&A in the chat box, and we'll get to them at the end of the lectures. We also want to minimize chats during the talk so as not to distract other attendees and the speakers. The program will be streamed live on BMSS YouTube channel in case anyone has difficulty with Zoom. The YouTube link will be in the chat, or type Bloodless Medicine and Surgery in your YouTube search. All right, so we'll get to our first speaker for today. We have the privilege of hearing from Dr. Nathaniel Yusoro at the University of Calabar Hospital. His talk is on why give 1 when 0 is best. Dr. Nathaniel Yusoro is a chief consultant general surgeon at University of Calabar Teaching Hospital in Nigeria. He is a fellow of the West African College of Surgeons and a fellow at the International College of Surgeons. He has served a full tenure position as head of surgery in his institution, during which time he instituted didactic lectures in blood conservation and bloodless surgery for medical students and residents in the University of Calabar in 2014, and he is still teaching those courses to date. Dr. Yusoro is the founder and chairman of the Bloodless Medicine and Surgery Group in University of Calabar Teaching Hospital, a multidisciplinary group of professional volunteers providing bloodless care for patients with excellent outcomes since 2007. He is a member of several international professional societies, including the Society for the Advancement of Blood Management, where he serves in the membership committee. He is the past president of the Bloodless Medicine and Surgery Society. Dr. Yusoro is passionate about improving clinical outcomes and protecting patients' rights through blood transfusion avoidance. He has presented several papers on the subject in international professional meetings, published in renowned peer-reviewed journals, and has a book chapter in his name. Dr. Yusoro is a recipient of several awards, including the 2016 SABM Award for Outstanding Leadership in Advancing Patients' Rights and Patient Blood Management. Thank you so much, Dr. Yusoro.
Thank you for that kind introduction, Cassandra. Please, I have some challenges in sharing my slides. So Schneider, please, could you share my slides for me? Thank you. So as you've heard, our topic is why give 1 when 0 is best? Recent evidence in favor of bloodless surgery. Next slide, please. I do not have any disclosures, but I am optimistic that one day I will have. Next slide. So I'm actually certified in patient blood management. Next slide. Both the fundamental as well as the advanced concepts. Next slide, please. I am also certified in bloodless medicine and surgery. Next slide. From some of the foremost institutions in the world. Next slide. I have spent time in bloodless programs, one of which is the one in Englewood Hospital in New Jersey, USA. Those in the blood management world would recognize Sherry, who for years had been the director of that program, the clinical director, while the medical director had been Dr. Chandler. So I was with them, with Dr. Shanda and Sherry, and I learned a lot of what I am about to share now from them and from the SABM. Next slide. Which I happen to be a member of, and I also serve in the membership committee of SABM. Next slide, please. I am also a member of the Bloodless Medicine and Surgery Society. I'm the past president, and I'm still there as the chairman of the board of trustees. Next slide. So what we want to discuss, having established my credentials, so to speak, we want to discuss why give one when zero is best. Recent evidence in favor of bloodless surgery. Next slide. So at the end of this talk, we hope to be able to explain the origin of the concept of giving 2 units of allogenic blood as a start dose, so to speak. We'll also be able to identify the reasons for the recent movement towards 1 unit transfusion, which many of us might be aware of. And then we'll be able to recognize why 0 units is the current standard of care. Next slide. So what do we already know about blood transfusion? There are some things we knew already. And next slide. The hazards of blood transfusion, we knew that. And as physicians, we tend to balance hazards with benefits. So we know that hazard also is a matter of chance. It might be present, it might not be present. So whether there are infectious hazards of blood transfusion or non-infectious serious hazards of blood transfusion, they could be present, but they may not be. Next slide. So even though sorry, I think you need to, okay, you can stay there. Yeah, you can. So even though there are very many hazards of blood transfusion, but it might not be there. The first hazard, next slide. The first one there, transmission of infection, is again a very long list. Next slide. And just leave the slide there. So you can see several infectious organisms that can be transmitted by blood transfusion. And out of these, how many do we test for? Basically 4, at least in my environment: HIV, hepatitis B, hepatitis C, and syphilis. We don't even test for malaria. So again, these are hazards. They may or may not be present. Yeah, there are newer and newer possible hazards also. Next slide. Yeah, next slide. So in my setting, 95% of donor blood is judged as I said, this. Next slide, please. Right, so talking about the origin of 2 units of blood, it has been the saying in my own area of surgery that if your patient needs 1 unit of blood, he doesn't need it. Use 1 unit. You want to raise the hemoglobin, it's just 1 gram. You're going to raise the hemoglobin by 1 gram per DL with 1 unit of blood. So that's like a drop, perhaps not in the ocean, but in the cup. And it doesn't significantly affect or benefit the patient that you raise the hemoglobin from 6 grams per DL to 7 grams per DL. So what? And it's uncertain. In many cases, transfusion actually makes the hemoglobin to drop. I'm sure many of us clinicians are familiar with this unfortunate scenario. Moreover, if you're just trying to raise hemoglobin by 1 gram per DL, you could use hematinics, whether oral or IV. That's not a problem. You can use that. So you shouldn't. If your patient needs 1 unit of blood, he doesn't need it. Or if, on the other hand, perhaps you're trying to replace losses, and if the replacement is just 1 unit of blood, you can use the normal saline or even colloid, 500 mils of colloid. So that will, if all that you're trying to do is to replace lost volume, 1 unit of blood doesn't really make a significant difference. Please, next slide. So it was said that if you must eat a frog, eat a fat one. So next slide. So if you think your patient needs a blood transfusion, the fact is that the hazards of blood transfusion make single unit transfusion not justifiable. You can't justify it when we already know all the hazards, infectious hazards, non-infectious hazards. And you're giving 1 unit of blood with all the hazards. So that didn't make sense. Next slide, please. No, please go back. So it was said you should transfuse 2 units and above if you think your patient needs blood transfusion. Because as the saying goes, if you must eat a frog, eat a fat one. Giving 1 unit of blood is neither here nor there. So give 2 units if you believe that your patient needs. Of course, that concept of a patient needing blood is currently challenged, but we are talking about the origin of the 2 units of blood stats. So with that, I hope I have been able to defend my colleagues around the world who have been accused of instituting 2 unit transfusion. That it wasn't out of malicious intent to poison the patient, but it was in consideration of the hazards, hazards of blood transfusion, which did not justify single unit transfusion. So if you want to do it, you might as well go to 2 units and above to really justify what you're trying to achieve. Next slide, please. So we knew about the hazards of blood transfusion, and we were trying to balance these hazards with the benefits. But we learned some more things about blood transfusion. Next slide. So we got to begin to learn about adverse outcomes of blood transfusion. And these authors, Maran van der Meel and others, described adverse outcomes as an unintended and unwanted event or state occurring during or following medical care that is so harmful to a patient's health that adjustment of treatment is required or that permanent damage results. So this was something else entirely, not having to do with hazards, but something so harmful to patient's health that adjustment of treatment is required. Or there can be permanent damage. Of course, what could be more permanent than death? Let's go to the next slide. Now look at this paper, which was published by Dr. Malone and colleagues up to 20 years back, or more than 20 years back. They wrote blood transfusion independent of shock severity is associated with worse outcomes in trauma. So these authors, they did a prospective study of 15,534 patients admitted in a level 1 trauma center over a 3-year period. And they stratified them into various groups, including injury severity score. And so they compared the transfused patients with patients who were not transfused. And what did they conclude? Blood transfusion is confirmed as an independent predictor of mortality, ICU admission, ICU length of stay, and hospital length of stay in trauma after controlling for severity of shock by admission-based deficit, lactate, shock index, and anemia. Now that was something shocking coming out in 2003, even though it seemed to have been largely ignored, that independent of shock severity, there are worse outcomes. This is not about hazards like HIV and all that, but the outcomes are worse in transfused patients compared with non-transfused. Next slide. So this is what, again, these authors found, that 22% of transfused patients died compared with 2.3% of non-transfused. Of the same category, this was case controlled. ICU admission 59% in transfused ones compared with 18%. Hospital length of stay 14 days compared with 3 days. These are naked eye differences. You don't need a statistician to work this out for you. It was clearly bad news for transfused patients. Next slide. So it led Dr. Ferraris to ask this question: why does intraoperative blood transfusion lead to worse outcomes? Next slide. And we could see two major causes of adverse outcomes have been elucidated over the years. We do not know the entire story yet, but we know that at least there are two major mechanisms by which blood transfusion causes adverse outcomes. One of them is storage lesions, and the other one is immunomodulation. Next slide. Right, so talking about storage lesions, that is to say that whenever we store blood, it degrades. And that degradation, both physical and biochemical, leads to actually reduced tissue perfusion and oxygenation, which leads to tissue hypoxia. That's not what we set out to achieve. We wanted to improve tissue oxygenation, but now we are causing hypoxia. And the increased viscosity and increased aggregability in the blood actually worsens the tissue hypoxia and leads to other problems like deep vein thrombosis and thromboembolism. Coagulopathy occurs due to blood transfusion, and that can lead to increased hemorrhage. Next slide. So you can see the changes in morphology in the red cells, originally biconcave, which is a physiological state, now becoming echinocytes, spheroechinocytes, spherocytes, and which is not at all suitable for delivery of oxygen at the tissue level. Those misshapen red cells cannot get to the capillaries. They simply block them. Next slide. So you can see the impact of storage on red cells. I'm sorry, it seems I lost connection. Can you hear me? Hello, Schneider, can you hear me? Okay, good. So next slide, please. Right. So this is a slide I borrowed from the Society of Thoracic Surgeons, courtesy of Dr. Spies. You can see that the hypoxia we cause whenever we transfuse can be up to 400% of hypoxia. Next slide. You can see all the on the previous slide, you could see all the other problems that are caused by blood transfusion, but it gets worse. Immunomodulation. This leads to transfusion related immunomodulation, transfusion related acute lung injury, wound infection, cancer recurrence and progression in transfused patients, allergy, reactivation of latent pathogens in donor white blood cells, graft versus host disease, etc. Next slide. So Blomberg and his co-workers figured that transfusion-related immunomodulation is perhaps the #1 cause of death in transfused patients, largely unrecognized. They talk about post-operative infection, cancer recurrence, and so on and so forth. Next slide. So you can see, please click once more. You can see, keep clicking, and again, and again, right, again, again. So you can see some of the points highlighted here, the attempt to figure out the mechanism of these problems. And then it says extensive data shows conclusively increase in cancer recurrence rates, 80% in colorectal cancer. That's not a small number. Post-op bacterial infection, 200 to 1,000% in some studies. So medical scientists know that we don't usually use the word conclusively lightly. It's only when we are sure that the problem exists. Next slide. Okay, keep going. Right, so this was an attempt to figure out the risk versus the benefit, because as I said, we are used to balancing risk with benefit. Click again. So what percentage of our patients suffer immunomodulation? The Society for Thoracic Surgeons says 100%, some degree of immunomodulation. Click again. So what percentage have some decreased oxygen delivery? 100%. It could vary in the degree, but virtually everybody transfused has a decrease in oxygen delivery. Next slide. And there is a dose-dependent kind of situation with these adverse outcomes. This is a slide, again, thanks to Dr. Ferraris, showing serious morbidity and mortality, increasing with the amount transfused in cardiac patients. You can see the bars going up from zero transfusion to more and more transfusion. Next slide. So when we talk about adverse outcomes of blood transfusion, we're not talking about hazards. We are talking about higher infection rate, higher tumor recurrence, poorer prognosis, increased hemorrhage, higher incidence of ICU admissions with tachycardia, venous thromboembolism, etc. Higher morbidity, greater length of hospital stay, higher mortality. And it is dose dependent. So the more we give, the more the problems. Next slide. So you can then understand how and why the concept of why give to when one will do came into existence. It was in recognition of the fact that there's a dose-dependent increase in adverse outcomes in transfused patients. So you can see here, Choosing Wisely Canada came out with this, why give to when one will do? And everyone thought, okay, what we need to do is reduce the amount of blood we transfuse. The concept of giving only when necessary came in. So cardiac surgeons that used to give maybe 20, 30 units of blood, they came down to 1 or 2 units of blood. And it was thought that that would keep every problem away. Only transfuse when necessary in quotes. Next slide. However, there are newer things that came out that puts a serious question mark on that concept of why give to when one will do. There are things we now know about blood transfusion in the past few years, which even if we knew before, maybe it wasn't so obvious. Let's see what these things are. Next slide. This is a seminal paper from Dr. Majed Refai and his colleagues, which you can see came out in 2021. That's just 4 years ago. Impact of RBC transfusion on peripheral capillary oxygen saturation and partial pressure of arterial oxygen. So what they did was to check do the pulse oximetry for transfused patients who received just one unit transfusion. So they assessed for hemoglobin level, peripheral capillary oxygen saturation, that's SpO2, partial pressure of arterial oxygen, PaO2, from 12 hours before and 24 hours after transfusion. Next slide. So what did they find? Lo and behold, there was actually a decrease in SpO2 in patients who were transfused. And as a matter of fact, the decrease was sustained, not as some people would think, oh, that's just at the initial phase. After 24 hours or so, everything will be all right. No, there was a sustained decrease. And in any case, that's not what we tell our patients. That's not what we set out to do. We don't set out to reduce the tissue oxygenation or to cause hypoxia. What we tell our patients is that we want to improve the tissue oxygenation. And we usually say we want to do it immediately. We want it immediately. That's why we're transfusing. But as we can see, rather than improving the tissue oxygenation, we're actually causing hypoxia. Next slide. Next slide, please. Okay, we've been through this. Okay, now, this was another shocking paper from the Lancet in 2022, saying resuscitation with blood products in patients with trauma-related hemorrhagic shock receiving pre-hospital care, a multi-center open-label randomized control phase 3 trial. So this time, there was a randomized control trial comparing patients who received packed red cells and lyophilized plasma before even they got to hospital. And these are patients in shock due to hemorrhage. And they are receiving these products in the hope that they will be better off. So they were now compared with patients receiving normal saline. Now, let's pause here and think about it. A few years ago, I think nobody would have given ethical approval for this kind of study because it was presumed that a patient in shock needs blood transfusion. So what are you trying to prove? Are you trying to kill people? So the very fact that this study was approved shows that there have been serious questions about the efficacy of blood transfusion. In any case, back to the study, what did they find when they compared transfused patients in shock with those who were just given normal saline? Next slide. Again, lo and behold, they said the trial did not show that pre-hospital packed red cells and lyophilized plasma resuscitation was superior to normal saline for adult patients with trauma-related hemorrhagic shock. A very modest conclusion if you compare with the conclusion that Malone and co-workers had made about 20 years earlier who actually found worse outcomes in transfused patients. But this time, it was a randomized control trial. They could not find any superiority of transfusion compared with giving normal saline. Of course, this is not to say that we advocate normal saline for patients in shock. In bloodless surgery, we actually know that we need to switch to colloids so as to avoid, that is after giving initial normal saline, we may need to switch to colloids to avoid the problems of giving excessive normal saline, like acidosis, fluid overload, and so on. But look at this. This was comparing blood transfusion with normal saline, and blood transfusion did not win. Next slide. And in GI bleeding, it has been found repeatedly that red blood cell transfusion, fresh frozen plasma, is actually associated with increased mortality and rebleeding in many cases. So why are we still using these things for patients who are bleeding? And yesterday, Dr. Blomberg reminded us that paper after paper regarding platelet transfusion has shown that outcome is not improved. Rather, platelet transfusion leads to more bleeding. That is again shocking, and yet it is still being used. So these things lack efficacy, both whole blood as well as component transfusion, they lack efficacy. That's what evidence-based science is telling us of recent. Next slide. So the lack of efficacy of blood transfusion, it can be summarized as causing hypoxia instead of improved tissue oxygenation. It's not superior to normal saline in resuscitation of trauma patients in shock. And it causes hemorrhage rather than stopping hemorrhage. There's increased mobility instead of lowering, and increased mortality instead of lowering mortality. Next slide. So there are many ramifications of this. But again, as Dr. Ferraris pointed out, more is known about the risk of blood transfusion than the benefits. Next slide. So there is actually no scientific evidence of benefit of blood transfusion. Far back in 2008, it was featured in the Current Opinion in Anesthesiology, a paper by Dr. Ron. The benefits of blood transfusion have never been conclusively demonstrated, but evidence of transfusion-related harm continues to accumulate. So at this time, it's like giving a bottle of beer to this infant. What is the benefit? Next slide. Medical ethics is based on 4 major concepts: autonomy, beneficence, non-maleficence, and justice. And strangely enough, blood transfusion violates all 4. Yes, because patient autonomy, if you insist on transfusion, then we're not respecting the patient autonomy. And even for patients who do not decline blood transfusion, beneficence, that we have seen no evidence, no scientific evidence of benefit, whether it's whole blood, component transfusion, no scientific evidence. Non-maleficence, there's a lot of evidence of harm. And of course, justice. Patients who decline blood transfusion are found to be better off. So what about those who do not decline? Why are we still giving them blood transfusion? Next slide. So there are hazards of blood transfusion. There are adverse outcomes. It lacks efficacy and is not evidence-based. And we can truthfully say that it's unethical. Next slide. But it gets worse. The concept of giving 1 or 2 units of blood, far back 2009, Dr. Bernard and colleagues had published that giving 1 or 2 packed cells is associated with increased 30-day mortality, surgical site infection, pneumonia, and sepsis in general surgery patients. So it didn't help that we said, let's give one or two of products which are not even efficacious in the first place, but are known to be harmful. Next slide. Again, in 2012, there was this paper by Dr. Ferraris and colleagues saying surgical outcomes and transfusion of minimal amounts of blood in the operating room found out that, in conclusion, there is a dose-dependent adverse effect of intraoperative blood transfusion. How did they get to that conclusion? Well, they queried the American College of Surgeons National Surgical Quality Improvement Program database for patients undergoing operations between January 1, 2005 and December 15, 2009. So they were able to get 941,406 operations analyzed in patients from 173 hospitals. And lo and behold, of course, they were taking account of patients who received just 1 unit of blood. And they had higher unadjusted rates of mortality and more serious morbidity. So giving 1 unit or 2 units does not help. They still have worse outcomes than those who are not transfused. Next slide, please. Right, so we can see that patients who receive intraoperative infusion of just 1 unit of packed red cells, they had worse outcomes. Next slide. But even more recently, this is now 2023, that's 2 years ago. This paper came out by these highly respected authors in the Annals of Thoracic Surgery. Incidence and impact of single unit red blood cell transfusion. Analysis of the Society of Thoracic Surgeons database. Obviously, the Society of Thoracic Surgeons has been shedding a lot of light on this issue and blazing the trail. What did they find? Next slide. So they found that these patients who had single unit transfusion, now we've come down now from 20, 30 units to single unit. They still had higher mortality, prolonged ventilation, renal failure, and reoperation rates. Note, more than patients who receive 0 RBCs. Yes. Patients who receive 1 unit of blood still do worse than patients who receive 0 RBCs. So that is where we are going. Next slide. So why give 0 when, why give 1 when 0 is best? That's the question now. Why give 1 when 0 is best? Because patients who receive 1 unit are still worse off than those who receive 0. So between giving liberal transfusion, then restrictive, maybe giving 1 or 2 units, and giving 0, it is 0 that wins out. Next slide. Again, far back 2002, the World Health Organization had said that simple alternatives to transfusion are safer, less expensive, and equally effective. Next slide. And again, in 2021, recently, the policy brief from the World Health Organization came out, the urgent need to implement patient blood management. And they said the concept that our own blood is still the best thing to have in our veins has given rise to various surgical blood conservation techniques, which of course have led to patient blood management. Next slide. So you can recognize here the 3 pillars of patient blood management. And you see, it says the overarching aim of PBM is to improve patient outcomes while saving health care resources and reducing costs. Next slide. And here we have a paper from Dr. Gubi saying patient blood management is a new standard of care to optimize blood health. Right, it's a standard of care. Next slide. What is standard of care? The NCI Dictionary of Cancer Terms says it is treatment that is accepted by medical experts as a proper treatment for a certain type of disease and that is widely used by healthcare professionals, also called best practice, standard medical care, and standard therapy. So using patient's own blood, as the WHO is recommending, is actually the standard of care, not using donor blood. Next slide. This article, a global definition of patient blood management by much published and world-recognized experts, Dr. Shanda and colleagues, says of patient blood management that it is a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. Next slide. So in that same article, they pointed out how it came about. It says the background and evolution of PBM. They traced it to bloodless surgery, the work of Dr. Denton Cooley in the 1960s and 70s, in which he showed that his patients who were having bloodless open heart surgery were coming out better. Next slide. So that was in 1962 that he performed the first bloodless open heart surgery on one of Jehovah's Witnesses on May 16. And he went on to publish thousands of cases that he had done. And they were not worse off. A lot of them were better off than transfused patients, very surprisingly. Next slide. So it is in honor of Dr. Cooley that we observe May 16 as World Bloodless Surgery Day. And it is within our Bloodless Medicine and Surgery Week. And so on Friday, we are going to listen to a World Bloodless Surgery Day lecture, usually given by a notable clinician and authority on the subject. Right now, this day is observed not only by the Bloodless Medicine and Surgery Society, but SABM, MyPBM, and various medical societies and institutions around the world. Dr. Cooley truly deserves credit because what he did opened the way and opened people's eyes to the fact that if you could do bloodless surgery with open heart surgery, then you can definitely do it with anything. Certainly with things like mastectomy and so on, and liver transplant and various transplants, spine surgeries, etc. So next slide. Right, so why give one when zero is best? That is the scientific evidence that zero is best, and that takes us to bloodless surgery. Next slide. And this is my modest contribution to knowledge in a book on blood transfusion. They have a chapter on bloodless medicine and surgery. And so we define bloodless medicine and surgery as the provision of quality health care to patients without the use of allogenic blood, with the aims of improving outcomes and protecting patients' rights. So it's not substandard care, it is quality health care. Next slide. So the theory and practice of bloodless surgery, far back 2002, again by these notable authors in transfusion and apheresis science. Next slide. They describe bloodless surgery as a comprehensive perioperative approach that has as its goal allogenic transfusion avoidance with a view to improving patient outcomes. You can see far back at that time, they already saw that it is no longer an issue of advocacy for patients who decline blood transfusion. This has to do with improving clinical outcomes. Next slide. They went further to say that it is a safe, effective team approach to medicine and surgery that reduces blood loss and uses the best available alternatives to allogenic transfusion therapy while focusing on the provision of the best possible medical care to all patients. That was quite prophetic in 2002, the statement to all patients. So to observe the ethical principle of justice in medicine, it is necessary to extend the benefits of bloodless surgery to all patients. And that is what the World Health Organization is trying to do in calling it patient blood management, to try and make people less prejudiced, less against these practices, and to understand that it is superior. Next slide. Recent evidence suggests that the application of bloodless surgery principles may result in improved patient outcomes, reduced morbidity and mortality, shorter hospital stays, significant overall cost savings to the healthcare system. So we are no longer talking about suggesting. We now have the hard evidence for all these things based on what we have shared here from recent studies. Next slide. You can see the pillars of patient blood management there: optimizing the hematocrit, minimizing blood loss, and supporting patient tolerance of anemia. Next slide. So Dr. Erin Soydam took us through these 4 pillars of bloodless medicine and surgery 2 days ago, on Monday, the first day of the Bloodless Medicine and Surgery Week. Next slide. Because there's an addition there, optimizing tissue oxygenation. But the first pillar is, of course, optimizing the hematocrit. Again, we had discussions on that the first day from Professor Lowe, Vernon Lowe from South Africa, and also Dr. Ofonimesien from my center here in Nigeria. They spoke extensively on optimizing the hematocrit. Next slide. Next slide, please. Right, so this is intravenous iron administration in my hospital in the female orthopedic ward. You can see that patient has some had lower limb fracture, and she actually had open reduction internal fixation without blood transfusion. Next slide. And on Saturday, we are going to hear from one of our notable speakers on erythropoiesis stimulating agents. Next slide. Minimizing blood loss. Again, we heard much from Dr. Soydam on this on Monday, and this is an important pillar in bloodless surgery. We also heard from Dr. Stephen Frank yesterday on this. So it's important for us to minimize blood loss for better outcomes. Next slide. Optimizing tissue oxygenation. Yes. So we know blood transfusion leads to hypoxia. So not giving blood transfusion already is a step in the right direction, but we do more than that. We actually administer oxygen, and we do replace volume, and we minimize oxygen consumption. So we actually achieve more through bloodless surgery techniques. Next slide. We follow what the WHO says and support the patient's physiological tolerance of anemia. Again, Dr. Soydam took us through this. And we need to take note of things that can actually kill the patient. The patient is in shock. They won't die from low hemoglobin. They're going to die from hypovolemia. So we need to correct that. They can die from acidosis, either due to the shock state or due to use of normal saline in resuscitation. So we need to recognize it and correct it, and so on and so forth. We want to avoid iatrogenic anemia due to excessive phlebotomy. Next slide. So there are many benefits of bloodless surgery: faster recovery, faster wound healing, lower wound infection rates, lower morbidity, fewer ICU admissions, shorter hospital stay, lower mortality, and of course we avoid infections and hazards of blood transfusion. There's better prognosis in oncology. better patient satisfaction. And us, the clinicians, we are more happy when our patients get well and go home. Of course, it's evidence-based and ethical, unlike blood transfusion. Next slide. So look at this article from 2023. Bloodless is more, leveraging patient blood management to reduce risk, reduce cost, and improve outcomes. From IARS, they're actually discussing here the article we showed earlier by Dr. Gubi, in which she said patient blood management is a new standard of care to improve patient outcomes. So they are reminding us that patient blood management is actually originating from bloodless care. And maybe it's time to go back to the future and call it by its real name, bloodless surgery. Next slide. So we have centers for bloodless medicine and surgery, a lot of them in North America. I've been privileged to visit Johns Hopkins on the invitation of the medical director, Dr. Stephen Frank. And there are lots of papers from that center showing superiority of bloodless care. Next slide. So this is just one of them, risk-adjusted clinical outcomes in patients enrolled in a bloodless program. Next slide. And you can see they found that overall mortality was lower in the bloodless group when they compared with the, in a case-controlled study, they compared with those transfused. They said mortality was lower in the bloodless group than in the control group, and so on and so forth. A lot of things were better. Next slide. And of course, including hospital costs. So in my own center, we do have a bloodless surgery unit, and sometimes we're invited by orthopedic surgeons, like this case, which we presented in SABM meeting some years ago, of this non-Jehovah's Witness who wanted bloodless care, and he had it, 76-year-old man with fracture of the right neck of femur. And we went through the techniques, the 4 pillars of bloodless surgery. We were able to raise his hematocrit ahead of surgery and institute techniques to minimize blood loss, including acute normal volumic hemodilution. And he was okay. He was home within 10 days. He was on his feet. And so it's possible in a low resource setting as well. Next slide. Okay, so this is a case report of a 32-year-old female who had road traffic accident about 100 kilometers from my center with a fracture, a closed fracture of the left femur. They successfully raised the hematocrit from 15% to 30% with EPO within 3 weeks, but they couldn't proceed for surgery. So they referred the patient to my center. Next slide. And the patient successfully had open reduction internal fixation using bloodless techniques, including tranexamic acid, vitamin K. And the blood loss from the anesthesiologist was virtually unrecordable. Next slide. And there she is, post-op hematocrit 31%, discharge 13-day post-op. Next slide. And home and happy. Next slide. Right, so there is a push now for having bloodless programs in sub-Saharan African countries, as this paper by a professor in nephrology in Port Harcourt is showing us. Next slide. Okay, click again. So he says here, bloodless medicine and surgery program is not for the sole service of JW Group anymore, but for the generality of humanity. And he quotes the father of PBM, recognized worldwide, Dr. James Isbister. A blood transfusion was previously seen as a gift of life, but the tables have been turned. The general perception now is that bloodless surgery and avoiding blood transfusion may be the gift of life. Next slide. So again, standard of care has to do with best practice. And you can see the father of PBM is referencing bloodless surgery as being actually the gift of life rather than transfusion. Certainly better than transfusing even minimal amounts of blood, 1 or 2 units. No, zero. Next slide. Zero transfusion is actually the standard of care. So why give one when zero is best? Next slide. So in conclusion, blood transfusion is not a scientific option for any patient, including trauma patients, because of its adverse outcomes and lack of efficacy. Bloodless care involves the use of evidence-based techniques under 4 pillars, which are simple, safe, effective, cheaper, and result in improved outcomes, according to the World Health Organization. So bloodless care is the ethical, evidence-based standard of care for all patients, including orthopedics and trauma patients. Next slide. So I would like to acknowledge Dr. Kamprubi, Dr. Spies, Dr. Refai, Dr. Blomberg, Dr. Ferraris, and many others who contributed to my being able to put this together. Thank you very much.
Yeah, thank you very much, Dr. Nathaniel Natusoro. It was an insightful presentation. We would, I know we have lots of questions for you, but that will be kept until the time for question and answers. So now I'd like to introduce the next speaker, Dr. Howard Magazine, and he would speak on use of intravenous iron in pediatric populations. Dr. Maxim is Associate Chief of Pediatrics and Newborn Medicine at Englewood Health. He is board certified in pediatrics and neonatal perinatal medicine and specializes in treating newborns, particularly those born prematurely. He received his MD from the New York Medical College. He did his internship in pediatrics at the Schneider Children's Hospital and a fellowship in neonatal perinatal medicine at Mount Sinai Gravis Children's Hospital. His areas of special interest are neonatal protocols, neonatal nutrition, and bloodless medicine. He is a member of the American Academy of Pediatrics and the American Academy of Pediatrics section on perinatal medicine. Dr. Martin has lectured and presented his work on fetal and neonatal conditions and diseases at various conferences and conventions. Dr. Howard Mason, we have your attention.
Thank you so much, and it's a pleasure to be back here again. As mentioned, my talk is entitled about intravenous iron in pediatric patients. Hold on one second. Fortunately or unfortunately, I have no financial interest or conflicts to disclose. So I wanted to start today just talking about some goals and objectives. I break it down into I have these types of talks into the 4 W's. Who are we talking about? What patients are we talking about? What indications? What conditions? When is about, especially in bloodless medicine and how we practice here at Englewood, is when is the best time to intervene? And I guess the most important part would be the why. Why is this the best thing to do? Why would we want to utilize certain treatments and modalities? And why would we not want to use other ones that may be considered or by other people as the standard of care or best practice? So today, I guess the who at all those W's leads us to intravenous iron and the use of it in the pediatric patient. It's definitely met with hesitancy. It's definitely met with some, by many people, with some difficulty and trying to convince them of its safety and efficacy. One of the main reasons you would use IV iron in the pediatric patient is for the common condition of iron deficiency anemia. We will talk about a couple of other reasons later, something I spoke about several years ago at this conference about neonatal anemia, where we utilize it, especially in the situations for our neonatal patients who may be NPO, who may need to have a little bit of a stronger dose. But today I wanted to focus more about iron deficiency anemia, the most common cause of anemia in pediatric patients. So just to make sure we all understand what we're talking about, and to everybody here who may be a little confused, so what is it? It's just the body is lacking iron stores to produce an adequate number of RBCs. And what is iron? Iron is an essential component of the manufacture of hemoglobin through the porphyrin chains, and therefore is the essential component in the backbone. And when you're lacking in iron, you're going to end up being anemic. We'll go through some lab definitions. On the next slide, we'll talk about hemoglobin. Ferritin, the serum ferritin, usually we see a level of 10 to 12, but so on sea level 10 to 12, and that would be in iron deficiency anemia, that would be lower. And transferrin, which is like the measure of the iron binding capacity, that's not utilized as much. I know it's one of the another one of the laboratory markers, but in pediatric patients, in trying to diagnose iron deficiency anemia, it almost always is utilizing pretty much just the hemoglobin, with sometimes using ferritin in patients with chronic illness, excuse me, or other pathological processes. This slide shows us the age-based hemoglobin levels in children and adolescents. This may be different for those of you who concentrate more on on adult medicine. Some of these numbers may look shockingly low, but this is what we normally see. There's a higher level at birth. There's a physiological nadir at about 2 to 3 months, and then as the child ages, becomes for pre-adolescent and adolescent, we'll end up back towards those adult levels. Two standard deviations below those means. You can see that to the right of that picture. Usually below that is where we really consider patients to be anemic. And you can see, like in the 3 to 6 months, 6 months to 2 year period, significantly lower levels. So what are the causes of iron deficiency anemia? So there's almost like a bimodal effect, bimodal process of iron deficiency anemia. We see it in infants. That's usually due to their diet, either exclusively breastfeeding without oral iron, excess cow's milk introduced, which is notoriously low in iron, and other reasons would be parents who did not introduce solid foods, especially some vegetables that have higher levels of iron, and really having just like an inadequate diet for an infant, usually somewhere around 6 to 15 months. The other time that we see another spike that we see is in adolescents, iron deficiency anemia. You can think some of that may do the diet of an adolescent. It's usually not that. Many times it's in adolescent females who have heavy menstrual bleeding, and are just unfortunately losing iron store and can't keep up with their iron stores during that period of time. But those are the two most common times that in the pediatric patient that you would see iron deficiency anemia. But there are other causes, and some of these are really where we have a lot of our information, evidence about the efficacy of intravenous iron in pediatric patients. IBD, inflammatory bowel disease, Crohn's, ulcerative colitis, significant causes of iron deficiency anemia, especially in the adolescent population, who are many times just being diagnosed, who may be not so familiar with their symptoms, with this sloughing and the bleeding and all the issues that are unfortunately associated with this illness, causing patients to have anemia, which is most likely due to iron deficiency anemia, decreased dietary, as well as decreased absorption from the GI tract. Chronic kidney disease, common cause of issues in terms of all sorts of anemia and iron deficiency anemia. Immune and rheumatologic illnesses will also have issues of iron deficiency anemia. And I apologize, I'm just looking at the chat for a second. And could see signs of that, as well as chronic GI illnesses other than Crohn's or ulcerative colitis. We see it sometimes in our patient population of neonates who have had, unfortunately, necrotizing enterocolitis, have spontaneous intestinal perforations, who end up needing parts of their small bowel removed, and have chronic illnesses from that. Many will fail oral iron, and oral iron is still going to be the first line treatment for these patients. But there many formulations have poor absorptions. Many patients, especially in these cases of more chronic illnesses, will have poor absorption, and many patients will have side effects. The number one side effect being GI irritation, upset, GI irritation, constipation, things like that. And especially in an adolescent patient, they will be very, very hesitant to take their oral iron and continue, and then further become more and more anemic. So when do we consider IV iron? When do we think it's the time to utilize that treatment modality? Obviously, it's fair of oral iron therapy. When patients have been on oral iron and given it a chance to work and it hasn't. In cases of severe anemia requiring rapid correction here at Englewood, again, we are hesitant. We are very hesitant to, as a bloodless center, to use transfusion. And when patients have severe anemia, especially those who are well tolerated to mildly well tolerated, we would like to rapidly correct them. IV iron, it would be a significant way to do that. Preoperative optimization, especially like example in orthopedic surgery, if we know of a patient that has to have a situation where we want to optimize them. I'm going to have a couple of case examples later in my talk, but we would use IV iron to help increase their iron stores. And especially also in chronic inflammatory conditions, which are impairing absorption, as mentioned before, IV iron is an excellent way to help optimize these patients and get them to the best possible life and best possible care they can have. This pictogram seems to be a good way to take a look at when you would want to do it. If you look on the left, classic iron deficiency, iron deficiency anemia, the young children, the adolescent female, their initial therapy should be oral iron. There's no reason not to try it. It's easier for them. It can be given at home, especially in a mild anemia. But if after 1 month you're getting a poor response, I would definitely recommend at that point at least having a conversation or talk about IV iron instead of the oral. In the iron deficiency and inflammation, chronic kidney disease, gastrointestinal conditions, IV iron should probably be the initial treatment, both because you would want to correct their anemia, but as well as without a corrected anemia, the other conditions and the other illnesses can't be adequately addressed. The third category, if you look on the left, the one on the bottom, we have severe iron deficiency anemia with or without active bleeding, symptomatic low ferritin levels. Then there, I believe, is a conversation to be had between the practitioners, between the patient's family, as to oral iron versus IV iron. And I think this almost comes down to, I don't want to say personal preference, but the softer reasons of making a medical decision. Do parents want to correct it quickly? Are adolescents willing to try the oral iron or come in for IV treatments? Excuse me. And you could have a conversation. But you can see in all three scenarios, IV iron definitely is an avenue and something that definitely should be discussed. I put this slide in. I don't think this audience needs to go over it. We just had a great talk about that. But the risk of blood transfusion in pediatrics is high. Alloimmunization, transfusion reactions, iron overload, infection risk, increased hospital stay and cost, all of the reasons why all of us know that no transfusion is the best way to go forward. And by utilizing IV iron, we will eliminate some of those cases where people feel forced to go ahead and give a blood transfusion. So what are the benefits? What do we see when we give IV iron? Why would we want to do it? Well, obviously, the answer is rapid correction of anemia. Instead of slowly building up through GI absorption of your iron stores, especially in a situation where the number one cause of this issue is low iron stores, the IV iron will quickly replenish them. It avoids the transfusion risk that we just mentioned. It improves surgical outcomes. We know that when you are optimized, that your body is going to heal, that surgeries that potentially have the the issue of significant blood loss, and especially in a patient who already has some iron deficiency, you're going to have better outcomes. You're going to get patients have decreased hospital stay, decreased cost, and improved long-term outcome. Obviously, IV iron has better compliance than oral iron. Taking out even the oral iron side effects, IV iron, as long as the patient is willing to come in and not putting up too much of a fight, you're going to get that response and not have to take it chronically day after day and keep moving forward, and you will see that. So going from there, now that we've seen the benefits of IV iron, we see the types of patients that could potentially benefit from utilizing IV iron. We'll talk about some of the common IV iron preparations. And I think this is where many in the medical community have been very hesitant to start utilizing it, probably because it just developed a reputation of having potential side effects and potential harm to patients, which of course we're trying to avoid. 4 common IV iron preparations that have FDA approval here in the United States. The classic long one is iron dextran. It's has approval for greater than or equal to 4 months of age. It is off-label use in younger patients. I do say that many NICUs do utilize it. It does require sometimes a test dose, but it has good efficacy. It is associated sometimes with some side effects, but it has good efficacy. Iron sucrose, which is probably the most common used. It's safe. It's well tolerated. It has approval for in all age groups, and is the most common form of IV iron used, I would say, throughout the pediatric population. Ferric gluconate, which is approved for use in chronic kidney disease patients, is effective in oral iron failure. It's really, like I said, it's saved for those chronic kidney disease patients who have such difficult times with erythropoietin and manufacturing of red blood cells to begin with, as well as having low iron stores given their disease state. And one of the newest ones on the market is the ferric carboxymaltose. It's approved for over patients 1 year and above. But while there has multiple different treatment prescription recommendations, and we will discuss those in a few moments, it has been shown to have single dose efficacy and able to utilize one time and really increase iron stores for those patients who need that. So I said we talk about dosing. The classic way of dosing IV iron is the Ganzoni formula, which is actually somewhat fallen out of favor, especially as the newer forms of IV iron have come across. It's you calculate your total iron dose is calculated by your weight, the difference in where you want your hemoglobin to be, times your iron stores. It's a complicated formula. For the IV dextran, I forgot, I don't have the up here, but I could send slides or notes out. The IV dextran, there's a complicated formula for dosing in terms of similar to the Ganzoni formula, using lean body weight and desired hemoglobin. But that's why the other ones have come into better use. I'm going to go back to the previous slide. The iron sucrose is at 0.5 milligrams per kilogram of iron, and that's a calculated dose. How you figure out what the patient wants to give, and you divide it over every 3 to 7 days to give the total dose. You can give up to 0.5 milligrams per kilogram per dose, and you have to figure out from the formulas how much total iron you want to give, and you divide doses every 3 to 7 days. Ferric gluconate, 0.12 mLs per kilo, which is really 1.5 milligrams per kilogram of elemental iron during 8 dialysis sessions to help improve in the chronic kidney disease patients. And then back to the ferric carboxymaltose. This is where we see these low doses, these smaller numbers of administrations. So for those patients who are less than 50 kilos, 15 milligrams per kilogram times 2 doses should be an effective treatment for iron deficiency anemia. For those who are more than 50 kilograms, 750 milligrams per dose times 2 doses should be effective. Those doses will be 1 week apart. And there is studies, and there is showing that there's potentially a 1,000 milligram per dose single dose efficacy of patients for ferric carboxymaltose for one-time infusion to improve iron deficiency anemia. Administration guidelines, for giving these. You want to monitor for hypersensitivity like any other IV fluid, of any IV treatment, especially with iron dextran. Depending upon the product, you would infuse over 15 to 60 minutes, given the manufacturer's recommendations. Pre-medication may still be needed for IV dextran, and obviously you want to observe post-infusion for adverse reactions. But much of the research has shown that these, especially iron sucrose in the newer models, are well tolerated without any side effects. So after you give it, what do you expect? So what we expect to see in a lab response from giving IV iron is in 5 to 7 days, you see reticulocytosis. In 2 to 4 weeks, the hemoglobin should start to rise. And the ferritin and the transferrin levels that should improve over that period of time as well. Obviously, it takes some time for the body with the increased IV stores to utilize it, but those are the lab responses you should be able to see. This slide shows the effectiveness of oral iron versus IV iron. The red line looking at the hemoglobin percent of normal measured over time, and the black line looking at ferritin as a measurement of total iron stores over a period of time. So if you look on the left, you see it's with oral iron, as your ferritin percentage goes up, on a relatively linear scale, the hemoglobin goes up. But if you look at the right on IV iron, you can see how fast your iron stores are increased, and then you can see a much rapider response of the hemoglobin. So pretty much within 2 weeks, you can see at 75%. While if you look at the 2 weeks on the left with oral iron, you're almost about 50%. While that may seem to be but if you look at it at 3 months, you're fine. Almost at 2 months, you're relatively fine. In a pediatric patient who is ill and trying an acute illness, especially in inflammatory bowel disease, especially in an adolescent who is really feeling the symptoms of iron deficiency anemia, the fatigue, the weakness, things like that, that month to 2 months is a long period of time. It is something that we want to see. And if the oral iron, and if you're not really getting a great response in the first month, that also leads to poor compliance, especially adolescent patients. They're not going to take medication. They're not going to take treatments unless they can see that it's making them feel better. And if they're not, you're just going to end up in a negative feedback where I'm not feeling better, I'm not going to take it, making them feel even worse. So I think it clearly shows the benefit of IV iron in these patients. So your clinical outcomes, your hemoglobin increase 2 to 3 grams per deciliter in 2 to 4 weeks, which shows that pretty much for many patients and many of our back to that slide looking at the hemoglobin levels is really coming up from the 2 to almost over 2 standard deviations away from the mean. Reduced need for transfusion. In classic iron deficiency anemia, we really don't usually get to transfusion, but inflammatory bowel disease, rheumatologic, chronic kidney disease, it definitely gets there. And especially in orthopedic patients, it improves surgical readiness. We also have all of our patients improved energy and growth. I was asked as well about pediatric orthopedic surgery use. So preoperative anemia is linked to, as mentioned in every study, it's the same as in adults, increase. So if you're anemic going into a surgery, especially a surgery that is known to have the potential for blood loss, you have increased transfusion risk, you have poor wound healing, and you have a longer recovery time. This is clearly from everybody else. And IV iron will improve all of these outcomes. If you have a situation, I know I mentioned the previous speaker spoke about that woman with the femur fracture. If you have an opportunity where you can delay surgery off of a trauma or anything like that to optimize the patient, it's quite clear that the evidence has shown that will improve outcomes and should be done. Safety profile, like I said, it's generally well tolerated. There's rare cases of either a hypersensitivity reaction or hypotension, which can be alleviated obviously through pre-medication and close monitoring. With ferric carboxymaltose, there is a risk of hypophosphatemia, so you have to monitor the phosphate. It's not really, almost all patients, is not really clinically relevant, but it is something to monitor. A couple of case examples from here at Englewood in conjunction with some of our colleagues at other institutions. Cardiac surgery. So we had a patient, trisomy 21, who needed an AV canal repair. Parents requested bloodless surgery. It does take, especially this was a baby about the 5-6 month of age. It does take some time to work with colleagues about that, about realizing the need for bloodless even in a baby. There are hesitants, but we spoke with them and we worked with them. His care was optimized. He came out of his physiological nadir. His care was optimized using IV iron infusions, erythropoietin infusions, and he was able to successfully have his AV canal repair done under bloodless with no need for transfusion. And he had a quicker stay, and he had a great recovery from that. Orthopedic surgery, we've had several cases here at Englewood. Couple involving fractures, a couple involving tendon repairs and ligament repairs. Really what it is it's unfortunately a lot of times it is adolescent females who have a relatively level of iron deficiency anemia. We both have preoperative management and postoperative management to maximize healing and success. Doesn't mean patients need to stay. A couple of those patients who had postoperative management came back in post-repair to our infusion center to have IV iron infusions to help maintain their anemia. And were all successfully done with great results. And inflammatory bowel disease. So we've done this in conjunction with several well-known children's hospitals, including CHOP here in the United States, where either we act as the primary or we work with their infusion center to help their patients maintain having a normal hemoglobin hematocrit and trying to avoid anemia. This really shows the benefits of telemedicine. So there are a number of patients in our catchment area, local catchment area, who don't really come here specifically for the Bloodless Center, but we're just being seen at CHOP. So those who may not be familiar with where we are, CHOP Children's Hospital of Philadelphia, obviously it's well known. It's a worldwide leader in pediatric medicine. It is about 90 miles. I am not familiar exactly what that is in kilometers. An hour and a half drive to 2 hours from our hospital here in Englewood. And a lot of patients in this area will utilize them for treatment and care of their inflammatory bowel disease. They get infusions, they get different medications, but one thing that we have done is helped with IV iron infusions in our infusion center here at Englewood to help manage their case. Again, it shows the benefits of telemedicine. We work with them. The patients meet with their physicians or practitioners, and they go forward, and we can work in conjunction to help maximize their care. Screening and monitoring. What should you be looking for when you are giving these IV iron? You want for both anemia as well as the treatment. Clearly, you want to keep screening your high-risk groups. IBDs, chronic kidney disease, adolescent females who are menstruating. You want to ensure that they are not anemic. You want to ask these questions. You want to be not missed out while looking for other things. You can monitor hemoglobin, ferritin, transferrin, phosphate if you're using the carboxymaltose formation, but different blood levels to make sure that you are getting what's best for your patients. Some of the barriers to use, and I think the top two ones listed here are the top two barriers of use. There is a lack of awareness on practitioners' parts about the safety and efficacy of IV iron, and there's fear of adverse reactions. I think in many things we do in pediatrics, there's always a fear of you're always scared of harming. Obviously, we don't want to harm any patient, but you're so scared of doing something that against other utilized that we've used in the past, you may be a little more at risk to potentially use new techniques and new technologies. Like other things, especially as there's limited pediatric specific guidelines. Medications are not always tested as in detail on pediatric patients. Everybody wants to give them the best possible care, but we are seeing that there is definitely growing bodies of evidence for the use of IV iron in pediatric patients. And as I said before, I think this is a great place for telemedicine to play a role for those both between patients and practitioners, but more so between practitioners and practitioners to discuss, to reach out, to talk to people who may be using it to help develop programs and to help develop treatments for those who would benefit. So just in summary, and the takeaway, IV iron is safe. It is effective in children. There is strong evidence, and it is underutilized, but there are definitely ways, and it should be considered. I think the times to consider it are oral iron failure, pre-op anemia, and unfortunately, children who suffer with chronic illnesses and chronic disease who would benefit, who should definitely be kept in a non-anemic state. I'm not sure if we're taking questions now. I'm happy to take questions. I'm not, hopefully, if we have a few, I can. But here's my contact information. Happy to, anyone wants to email, that's the phone number here in the United States. If you ever want to call, and I thank you for inviting me today. I forgot to include the slide. I just want to give some acknowledgments. When I first joined Englewood 14 years ago. I came here just to be a neonatologist, and I was introduced to the world of bloodless medicine by people like Dr. Arya Shanders, Sherry Ozawa, now Dr. Margit Kaufman. And it is and this idea to take it worldwide and utilize the techniques we've been using here for great results and great efficacy and great patient satisfaction. And I would be neglect to not acknowledge them. Thank you very much.
Thank you, Dr. Mazine. Great presentation. We really appreciate your time, your effort, and all the work that you do, your dedication to the field. Next up, our next speaker is Dr. Craig Epperson. Dr. Craig specializes in the treatment of orthopedic disorders in children. His main clinical interests lie in the treatment of scoliosis and spinal disorders. His talk is entitled Bloodless Pediatric Orthopedic Surgery. And also he attended the University of Pennsylvania before completing his medical degree at the University of Medicine and Dentistry of New Jersey, Robert Wood Johnson Medical School, and his native state of New Jersey. Dr. Epperson finished his orthopedic residency at Brown University. He furthers education and training with a fellowship in pediatric and adult orthopedic trauma at Brown University, followed by a fellowship training at the renowned Texas Scottish Rite Hospital for Children in Dallas, Texas. At Scottish Rite Hospital, Dr. Epperson served as the Edwards Fellow in Pediatric Orthopedics and Scoliosis. Dr. Epperson is a professor of orthopedic surgery at the Brown Medical School and an attendant as well. Is author of numerous chapters, scientific articles, and national presentations related to the orthopedic care of children. His current research interests include the treatment of spinal disorders via a minimally invasive approach, improving the success of limb lengthening procedures, and the treatment of pediatric musculoskeletal injuries. In addition to his clinical duties, Dr. Epperson is the vice chairman for the education of the Brown Orthopedic Surgery Residency. Dr. Epperson believes that training the next generation of orthopedic surgeons is a tremendous responsibility and privilege. He has a passion for education, as he has helped develop the curriculum for educators for members of the Pediatric Orthopedic Society and has lectured on the topic to international audiences. On a personal side note, Dr. Epperson and his wife, Denise, a pediatrician, have 3 sons and live in Cumberland. In his free time, Dr. Epperson has been active in coaching flag football, soccer, and baseball. He also enjoys skiing, fly fishing, and enjoying the outdoors. Thank you, Dr. Epperson.
All right, let me share here. Let's see here. Can you see my slides? Not yet. Anyway, let's try this here. Okay, well, thank you. That was a very, very long introduction. I appreciate that, and I appreciate being invited to speak at this excellent conference again. So my take on this, you've heard this morning, a lot of this overlap here. We have a reasonably sizable Jehovah's Witness population, which is how I initially got interested in bloodless surgery, but by using lessons that we've learned, we're able to kind of help all of our patients. So I think this is the theme of this meeting. And so I'd like to share a little bit our experience with these patients. So scoliosis surgery, it is something we do quite frequently. About 1 to 3% of the adolescent population will have scoliosis. Children with neuromuscular disease like spina bifida and cerebral palsy and other disorders have a much higher incidence. And spinal fusion is a major surgery with major potential for blood loss, but it also is elective. And so for an idiopathic patient, they can lose about 40 to 50 cc's of blood per number of levels fused. And neuromuscular patients can usually have clotting abnormalities, and they can lose up to, almost 80% of their total blood volume. So this is something that's ripe for improvement for using bloodless techniques. And so as we've heard over the course of the morning and the meeting, there are many reasons that we just don't want to give blood in general, right? And I'm not going to go through all these again. We've been covered in detail, but clearly a transfusion has multiple negative side effects. But we also have scenarios in the Jehovah's Witness population where we can't give blood, and whole blood is out, including all the subcomponents, and the willingness of the patient and their family to accept things like cell saver and other plasma fractions and platelet fractions is really a personal decision. So really having some facility with working through these issues is really important when taking care of these patients who are going to have a surgery with a predictable potential significant blood loss. So this all starts in the preoperative period. So as you've heard, we really want to maximize the patient, and this figure of a patient, the center of center of a wheel is really important, right? Because there's a lot of other folks involved in the care, both from your intensivist, your anesthesiologist, your neonatologist for the young kids, the pediatricians for the older kids, transfusion-free medicine, et cetera, right? And we really have to kind of bring everyone together and maximize the patient. There are multiple options often for how we're going to go about surgically treating the patient. And again, involving colleagues is crucial. And just because we usually do something a certain way to treat a certain condition, there are often, as I mentioned, other options. And I think sometimes tailoring the surgical procedure to the needs of the patient with regard to blood loss, just like we tailor it to the needs of the patient for many other reasons, is crucial. And so we want to maximize the patient. So pre-existing anemia can be treated. There are certain supplements that people take, like garlic or fish oil or NSAIDs if they're having pain, or if they have valvular disease or some other disease, so they're on anticoagulants. So knowing their clotting history and the medications is crucial. And then again, a lot of the patients, particularly the neuromuscular patients, often have underlying disease of the kidney or the GI tract, which can affect their ability to clot or their baseline anemia. So we do a blood screening, and it's really interesting, the number of idiopathic patients. I just had a boy 2 weeks ago who has no history of clotting and has factor VII deficiency. So we find these things, and it gives us the opportunity to prepare and minimize the risk of catastrophic bleeding. So doing a standard workup, as you've heard about, is important, and we really utilize our hematology team very, very liberally. We've had patients, with undiagnosed von Willebrand's disease or any of the other coagulopathies. So really having that team available is crucial. And again, we've heard a little bit about this. Our last speaker mentioned the Ganzoni formula. But essentially, when we have our preoperative hemoglobin, we can kind of decide where we want it to be to optimize it. And then we have multiple options. And I'm not going to go into this because it was done at the expert level by the previous speaker. So I won't make you listen to the amateur version. EPO is something that we use, and for those patients who have a hemoglobin that's not really super low, but somewhere in the 10 to 13 grams per deciliter range, may be candidates for preoperative EPO. Iron is something else, as we've heard about, that can be helpful. But the point is to try to use our tools for the patients ahead of time to try to get their hemoglobin to a good level so that we have a little bit of a cushion. Nutrition is really important, both for patients who have had underlying GI surgery or necrotizing enterocolitis or other malabsorptive syndromes, but the neuromuscular population often are chronically malnourished, and there are patients that we recommend getting a preoperative G-tube. And so all of our patients on our neuromuscular pathway are seen by a GI service and the nutrition service. And things like total lymphocyte count and albumin can be very helpful. And we know when they're particularly low, you have difficulty with all aspects of the surgery, particularly healing. And the infection rate is higher. Vitamin D, B12, and folate levels are also important. And again, maximizing the treatment of their other diseases is really important. We've done some work using blood sampling from postoperative drain showing that neuromuscular patients are immediately at a state of inflammation postoperatively, whereas healthy patients have a delay. So there's this chronic inflammatory state that a lot of these neuromuscular kids live in, which obviously affects, their entire systemic functioning. So the key is really discussing the intraoperative options with the family. And there have been multiple studies looking at risks for transfusion during adolescent spine surgery. The key ones, neuromuscular scoliosis, number of levels fused, and use of Ponte osteotomies. And I'll talk a little bit about that later. But we have the ability to correct very large curves by taking away segments of the bone intraoperatively, but this usually increases the bleeding. And there are some other strategies that I'll mention that we've utilized with good success. And so we want to do a risk assessment. We want to improve our intraoperative coagulation. We'll talk a little bit about things we do from the anesthesia perspective to help with that. We want to minimize bleeding, and this is a technical aspect of the surgery, and I'll discuss some of the ways we do that. And we also want to decrease the infection risk. If you look at the blood loss we typically see from a neuromuscular scoliosis, for example, we can usually get the patient through the surgery without a transfusion, but their hemoglobin is certainly going to be low. If they have an infection in the first week or two where they haven't really responded, often because of the hyperemia in the wound bed from the recent surgery, the blood loss from a debridement for an infection, which also can be life-threatening, it can be more than the original surgery. So I think, if you're really trying to minimize the risk of transfusion over the treatment course of this patient, decreasing infection risk is a key feature. So what can we control from an anesthetic perspective? Well, keeping the patient's temperature normal is important. As they get cold, they often become coagulopathic. We use kind of strategically planned hypotension. One of the issues with correction of large curves is maintaining perfusion to the spinal cord. So prolonged hypotension combined with stretching of the spinal cord during a correction of a scoliosis can lead to neurologic deficit and paralysis. So that has to be really kind of laid out ahead of time. And we typically have that discussion as part of our preoperative time in or time out procedure where we want our mean arterial pressures to be. Hemodilution has been used to some success. We don't do a ton of it. When I was a fellow, we did a lot of it. There's concern over prone positioning, blindness, and some other side effects of hemodilution, but that is another option. Epidural anesthesia kind of can lead to some hypotension. We generally don't use that for the scoliosis cases. Erector spinae blocks with epi can also help bleeding in the muscle. We do use tranexamic acid, right? We usually use a bolus dose of about 10 to 20 milligrams per kilogram. And then we usually use about 20 milligrams per kilogram per hour continuous drip. And patients with underlying clotting disorders, obviously having DDAVP or factor available is obviously crucial. So many Jehovah's Witness patients will permit cell salvage, and they require a closed circuit. So the blood basically gets suctioned, goes into the machine, gets spun down, and immediately gets transfused back to them. So they get a packed cells with a hematocrit of about 80%. So roughly, we give them back about a third of the blood they lose. So this can be a very helpful option. And then surgically, there are multiple tools that we have to minimize bleeding. So, excuse me. We use a spray-on collagen thrombin as available in some centers, fiber and sealant. The U.S. military has developed a kaolin-soaked sponges, and the Aquamantis is a bipolar sealant that uses kind of heated water to kind of shrink the collagen in the vasculature, and really helps over a broad area control some of the bleeding, which in neuromuscular patients can be significant. So all these things are helpful. We also use surgical strategies to limit ongoing bleeding. So using a skilled assistant So this is, in my institution, many institutions that do a lot of these surgeries, it's a training center. So, taking someone through the procedure is going to lead to more blood loss in general. So having a skilled assistant so you can kind of move quickly and minimize blood loss, because the longer the case, the more blood you're going to lose, is important. Skilled neuromonitoring is important. If you're going to really run that threshold of the mean arterial pressure very low, it's really important that you're monitoring the spinal cord. And having someone that can really help you and understand the nuances is crucial. We monitor all of our patients. For very large cases, for the neuromuscular patients, excuse me, what I'll often do is those are usually a fusion from the top of the thoracic spine all the way down to the pelvis. So what I'll do is I'll expose the bottom half of the spine first, get my my screws or my instrumentation in the lumbar spine and the pelvis, and then really pack with sponges and kind of loosely kind of close the muscle tissue to minimize bleeding, and then expose the top half and do a similar thing. And then when we're done, we expose the whole thing, and we can put our rods in. So that really limits the blood loss there. And then we also establish, particularly with Jehovah's Witness patients, frequent checkpoints, right? So when you do your exposure and you'd say, okay, are we doing okay? And usually you are. But if you're finishing all the screws and you've come to a predetermined level of hemoglobin that you think is kind of dangerous, you can always stop and stage the procedure, right? So trying to decide at what points are we at the point of no return and we have to just keep going? At what points do we have the opportunity to stop and complete the procedure at another time? And we have those discussions with both the anesthesia team as well as the family. Fortunately, it's rare that we have to use those, but it really forces everyone to take stock of the bleeding situation and the status of the patient at multiple predetermined points during the surgery. So it's a good strategy really for any surgery. And then, as I mentioned previously, very large curves have been shown to increase the blood loss. And often that's because of the need for osteotomy. So what we basically do, and obviously these schematic drawings are much cleaner than we see in the operating room, but you're basically removing the joints and the ligaments between the bones. And so if you were to look in here, you actually are in the epidural space. So you're disconnecting the back half of the bones at multiple levels. And, you typically have a fair amount of bleeding. There's some epidural bleeding that's hard to control sometimes. And you can easily lose a lot more blood when you do these osteotomies. So if we have a very large stiff curve that we can't correct with standard techniques or osteotomies, it's helpful to have other strategies. So like this, looking at this, 150-degree curve, pretty certain that this is not something that's going to just immediately straighten out very quickly when the child goes to sleep. So using preoperative traction, we put a halo, which is basically screwed into their skull, and we have a whole traction setup, and I'll talk about that. We can use intraoperative traction. We can use temporary internal distraction. We can accept less correction. It doesn't have to be perfect. If you look at this x-ray, it's certainly not perfect. We have fewer implants in there, but the patient is very well balanced. It's a neuromuscular patient. So when they sit, their head is centered over their pelvis, which is our goal. And we've been able to accomplish that with a little bit lower risk, decreased surgical time and decreased bleeding. And then obviously a staged procedure is always an option for these as well. And so this is our traction setup, and essentially it involves either springs or in this case, this is a spring scale, and we have wheelchair and walker versions available, and we can build up to about 75% of the patient's body weight, and over a course of a few weeks, we can slowly put traction on the spine to elongate it. This is also a great time to really get to know the family. If it's someone that's been referred to that you're just meeting, we've used this time to do iron infusions to maximize nutrition. And so it gives you a little bit of pre-op time to get some other preparatory work done at the same time, decreasing the stiffness and size of the curvature in order to maximize the ease of our correction. Right. This is intraoperative traction. You can't really see the halo. It's kind of under this hair. But we can use skin traction tape for neuromuscular patients. If their pelvis is tipped and they're having trouble sitting, we can do that on one leg more than the other. It gives us the option to apply a slow and steady traction to a large curve during the procedure. And this is temporary internal distraction. And so this is actually a patient I took care of. I go to Honduras every year to do spinal surgery at one of the small hospitals in San Pedro Sula. And, this patient actually was a Jehovah's Witness and had a very large curve. And there we have a lot of limitations, obviously. Our ability to do a pre-op workup is sometimes limited. Sometimes the patient just comes in on our Sunday clinic and we have to kind of work through that. In order to do Cell Saver, the family or the institution has to find a qualified perfusionist, and they're often very expensive or not always available. So we didn't have that option. And preoperative traction is not an option because we're there for a week and we don't really have anyone who can manage that. So well, in these situations, this is the child's curve, and we knew this was going to be a large curve, and we knew that osteotomies were not a great option for the aforementioned reasons of blood loss and risk from the osteotomies. So you basically put all your fixation in, and then you can kind of put two temporary rods and connect them through a little linkage here. And then as you're working over time, you can slowly loosen that linkage, distract the spine, push the spine apart, and actually gradually correct the scoliosis in a way that allows you to minimize the neurologic risk, avoids osteotomies, and actually can get you where you need to be. So this is what the patient looked like before, and we're able to get a pretty reasonable correction with using that technique. And fortunately did not have to lose a lot of blood, and the patient did very well. So stage procedures, sometimes it's planned. There are some procedures we do that we know are extensive. And we plan it, but other times, based on our established stopping points, we might say, hey, we've gotten to this point, and for whatever reason, we need to stop, and we'll come back later. We can use things like the erythropoietin, iron, and proper nutrition between the stages. We can do traction between the stages. That's a helpful thing. It's really important to discuss the goals of the procedure with the entire team, including the family, because really you stage it when you can't get where you need to go in one setting. So if you decide, for example, that first case I showed, that you can accept a little bit of a larger residual curvature as long as you've achieved a level sitting balance of the pelvis, and adequate stabilization, you've reset what you're trying to accomplish, and you can get it done in one spot. If you can't, then it's sometimes helpful to know that ahead of time and just plan a stage procedure. All right, so for our children that we see at our hospital, we try to identify our high-risk patients, and these can include patients with medical comorbidities or the Jehovah's Witness population. We involve our transfusion-free medical service. Hematology folks are very actively involved in these patients. We have a complex child preoperative anesthesia service, so we do a preoperative assessment. This is not the patient that's met by the anesthesiologist the morning of surgery. We try to get everyone on the same page well in advance of these elective surgeries. We liberally consult other specialists, pulmonary specialists, GI specialists, nutrition, cardiology, anyone who's going to help the patient minimize postoperative complications and maximize their health prior to surgery is involved. We schedule these ahead of time with a skilled assistant and a high-risk anesthesia team. And also, we have a few preferred neuromonitoring technicians who are excellent that do some of our more complex cases as well. We usually will have a family meeting where we involve their clergy if they're interested, and a transfusion-free medical service representative, and any other physician who is integral to their care. There are some patients who have super complex problems that require large surgeries that are highly likely to need a transfusion. If we can't find an option that is lower risk, and the family really feels that the transfusion is absolutely not an option, even in life-threatening cases, we do have an ethics board. That's not really been, fortunately, necessary, but we have had patients, for example, who have been transferred to our center after large scoliosis surgery with massive infections. And again, due to the blood loss, we've been able to work around that a little bit and kind of stage some of their treatment. But there are cases where you can really get into a life-threatening situation. So you really have to have that conversation with the family and make sure that everyone is on the same page. All right, so here's an example. This is a 13-year-old girl who was referred to me for scoliosis. She'd seen another physician previously, but the family had not followed up, and she's otherwise healthy. And the family noticed that she started to look more crooked to them, and she's a Jehovah's Witness patient. So we got our transfusion-free medical service involved and hematology, and we try to meet with the family to understand what their belief system entailed and what their goals were for the procedure. So no blood products were permitted, but cell saver, EPO, TXA, or iron were all okay. And we discussed multiple options, including staging the procedure, traction, and others. So we did a lab workup, and the hemoglobin was a little on the low side. She also was positive for sickle cell trait, and hematology was very helpful here. There's some concern, particularly with full sickle cell, that using cell salvage can trigger a sickle crisis. So that would be something we'd obviously want to avoid. And using these lab values, we were able to lay out a strategy. So we decided to do IV iron and folate as well as erythropoietin preoperatively and got her hemoglobin up to 13.2. We involved the hematologist, perfusionist, as well as anesthesia to talk about any potential cell saver risk with the sickle cell trait, and also discuss the risk of thrombosis by using TXA as well as erythropoietin. Sometimes the kids respond very aggressively, and I had a boy, for example, that I think his hemoglobin went up to about 17, which is fairly high. And so we discussed preoperative traction and the checkpoints, and we also discussed in this population what is the Rhode Island law in life-threatening emergencies for children. And typically, if they're younger children, you can get a court order if it's a life or death situation. If they're older children, and 14 I think is the age they use in Rhode Island, and they don't want blood, then you can't give them blood. So just knowing what the rules are for Jehovah's Witness patients and transfusion and wherever you're taking care of these children is really important. You obviously want to respect their beliefs, and I usually will have this discussion that we absolutely respect their beliefs and have a whole system in place to work with them. But we have our own beliefs in terms of, the ability of a very young child to make a decision. And it's hard for us to just give in and say, yes, if the child's not going to survive, that's okay. So I think having that conversation is important. And parents, in my experience, are very understanding, and they of my belief system and our belief systems. And I think as long as there's mutual respect, it works out well. So she chose preoperative traction. So you can see you can kind of stretch this out quite a bit. And we got our team in place. And we're able to do her spinal fusion. And again, we try to figure out, based on the formulas available, what is our maximal acceptable blood loss? And we said, well, we can get about 1,700 cc's of blood loss, which would be a tremendous amount of blood loss for this type of surgery, by the way. About 20% of her blood volume would be about 800 cc's. So we try to ideally move quickly. You can usually do this in 200 or 300 cc's, which is a very small percentage of their blood volume. We use intrathecal morphine, which keeps them a little bit hypotensive, and that could be managed with pressors in the ICU postoperatively in order to keep them at the right level to minimize the ongoing bleeding that comes from this large wound bed. And you can see we did a kind of a little sparing instrumentation. We didn't put screw in every bone, but we got a very nice correction. And more importantly, got her through safely. So the summary is that blood conservation is a team sport, and communication is key. And for elective surgeries, particularly a large elective surgery like a spinal fusion, plan ahead, be flexible, both your own personal ethos, be flexible, but also get the curve flexible, and assemble a great supporting crew. And we're very fortunate, or I'm very fortunate to have an amazing team, at Hasbro. So it makes my job a lot easier. And this is my supporting team at home. So thank you for your attention. And this is, I think I sent in a PDF of this. These are some of the references if you guys want access to these.
Craig, that was good. Thank you very much.
Sure.
That's the last talk for the day, and it's time for question and answers. My three speakers, I guess you have access to the chat. And I haven't seen any questions yet on the chat. Nat, have you seen any questions on the chat?
Hi, did you say something, Innocent?
Have you seen any questions in the chat?
Oh, there are some comments. Maybe
Okay.
you want to highlight them.
What? Let me see. Start now. Okay, question and answer. Beautiful.
Sorry.
Okay, I have one one from David Brown. Closed circuits for cell salvage in JWs is a personal matter. Many will accept closed circuits as set up for other patients. Okay, and then let me just comment on that. It's closed circuit. Well, for those who understand cell salvage, cell salvage is usually closed circuit. Although um, when practitioners do normal volumic hemodilution, then that's not closed circuit. All right, okay, I have okay, Obada Seraye. Preoperative traction has been a useful tool. I have found it quite useful in a resource poor environment and lack of neuro monitoring. It greatly reduces the curve and blood loss counseling. Okay, fine. Thank you very much, okay? And thank you for pointing that out. So apparently there are no questions. That means you've thoroughly confused us.
Or convinced us.
All right. So it's been a beautiful outing. I think Cassandra may want to say one or two things.
Sure. Thank you all for joining us today. And we just want to highlight tomorrow's session. So we hope that you can join us tomorrow. We have more speakers. So one of the topics is bloodless total knee replacement and low resource settings. We also have a keynote address, blood salvage and bloodless orthopedic surgery, followed by Q&A. And we also have industry presentations from blood banks to bloodless care, and also HemaQ as well. So we look forward to you joining us tomorrow for those speakers. Have a great day.
Thank you very much.
See you all tomorrow for those who will be here.
Thank you, everyone.